Morning, muy buenos días a todos y a todas. Vamos a esperar
Good
un
morning,
minuto
everyone.
para
We're
que
going to
entren todos
wait
los participantes para
a
este webinar.
minute to let everyone in this webinar. Thank you.
Están entrando, ya tenemos más de
I
200
see
personas
people
conectados,
logging
pero les
in. We
damos unos
have
minutos
a little
más
over 200
porque
people
recién se
online. We're
abrió la
going to
sala.
allow for a couple of more extra minutes
We're
because
just
we
going to
just
wait
opened the
one more
room.
minute to allow people to enter the room. We only just now opened the room to give people access. Good. Well, I think we're ready to start. Muy buenos días a todos y todas y
Good morning,
bienvenido a este
everyone.
webinar de la
Welcome
Organización
to this
Panamericana de
webinar by the
Salud.
Pan American
Our
Health
webinar today will
Organization.
be in English, Spanish, and Portuguese. And for this, we have translation. There's a button at the bottom of your screen titled Interpretation, and please select the language of your choice using that button. And we also welcome interaction. We know we will have hundreds and hundreds of people connected to this webinar, but we do want it to be as interactive as possible. So please send us your comments in the chat. There's a chat icon at the bottom of your screen. So please join us today in this webinar on NCD and risk factor surveillance with a focus on telephone surveys. And to begin our session today, we have a message from the PAHO director, Dr. Jarvis Barbosa, who's a public health leader known to many of you and who'll speak to us about telephone surveys as a valuable tool for NCD and risk factor surveillance.
Distinguished participants, ladies and gentlemen, it gives me great pleasure to welcome you to this webinar titled Telephone Service, a resource for non-communicable disease and risk factor surveillance. Surveillance is an essential public health function, yet surveillance of non-communicable diseases in the region of the Americas remains insufficient, with persistent data gaps that need to be urgently addressed. Innovative approaches, such as telephone service, offer a valuable opportunity to strengthen non-communicable disease surveillance across the Americas and help to bridge these gaps. Surveillance plays a critical role in monitoring non-communicable diseases in a timely manner, supporting the assessment of health policy implementation and informing decisions to strengthen non-communicable diseases responses. Robust surveillance systems also facilitate early disease detection, identify at-risk populations, help to reduce health inequities, and ensure that health systems can effectively meet the needs of people living with NCDs. Today, I want to highlight how telephone service can strengthen our surveillance capacity for NCDs. PAHO's Rapid Mobile Phone Service, RAMS, was launched in 2020 to collect data on non-communicable diseases and access to care during the COVID-19 pandemic, and on the implementation of the WHO Best Bus policies and interventions for NCDs. To date, RAMPS has been implemented in 80 countries in the Americas. It complements household service by producing timely, cost-effective data that do not require physical or biochemical measurements. Ahora continuaré em espanhol. Utilizando o RAMPS, Uruguay
Using
evaluou as
ramps,
percepções e
Uruguay
performances
valued
sobre etiquetado
perceptions in the
frontal em
audience
produtos
about front labeling
ultraprocessados
in
consumados nos
ultra-processed
meios.
foods.
8 de cada 10 pessoas
8
adultas
out of 10
reconheceram
people,
os símbolos de
adult people,
advertência por excesso de
recognize
açúcar,
warning
graxa
signals
ou sódio,
about
e el
added sugars, added
63%
fats,
afirmou que las
etc.
etiquetas
And a
influyeron en
large
su decisión
percentage
de elegir opciones
recognize
más
that
saludables.
these labels
RAMPS também
led
pode
them
ser
to
uma
make
ferramenta útil
healthier
para
decisions.
ajudar
RAMs
a
can also
identificar
be a
barreiras
very useful
en el
tool to
acesso à
identify
atenção
barriers
sanitária,
in
como o acesso
healthcare
limitado a
access.
serviços
specifically talking about NCDs, limited access, and lack of financial resources that prevent a large number of people to access the healthcare they deserve. Another initiative is Vigitel from Brazil. This is another phone survey initiative that helps monitor NCDs as well as risk factors. For almost 2 decades now, Vigitel produces data on a yearly basis, and they guide interventions in public health policies, adapting itself to the country's information needs. The Americas offer a favorable setting to explore mobile phone surveys. In 2024, 4G and 5G networks reached 93% of the population. However, there are still gaps. Urban coverage is only 98%, while rural areas it's 72%. This disparity continues to be a challenge. Despite these restraints, phone surveys continue to be affordable, agile, and scalable tools that complement in-person surveys and strengthen NCD surveillance. PAHO reinforces their commitment to support countries in integrating NCDs into public offices for surveillance. And we encourage you to participate actively in this space and learn more about the role that phone surveys can have in reducing the burden of diseases, specifically the burden of non-communicable diseases in our region. Thank you. Thank you, Dr. Jarvis Barbosa, Director of the Pan American Health Organization. Thank you for these welcoming remarks for today's session, this webinar about phone surveys.
Well, in today's session, we're going to really have a spotlight on the role that surveillance plays as an essential public health function. And in NCDs, a really important function to help guide not only understanding of what the burden of NCDs and risk factors are, but also what the health system response is. And we really want to showcase the use of telephone surveys as an innovative tool to monitor NCDs, and especially looking at how we can monitor access to care and that health system response. And we're really excited because we're going to talk about not only from PAHO's perspective, what's going on in the region on NCD surveillance and how PAHO is committed to supporting member states to strengthen NCD surveillance, but we have with us some of the leaders in the field of NCDs and NCD surveillance from our partners at Resolve to Save Lives, as well as we're going to share some experiences from the region, from Brazil, from Vigitel and Uruguay on ramps, as you heard from the PAHO director. So let's get started with our exciting program today. And I'd like to invite our first presenter to help set the scene for us. She's Dr. Roberta Caixeta, the PAHO advisor for NCD surveillance, prevention, and control. And she's leading PAHO's regional efforts to build capacity on NCD surveillance. And she's going to talk to us about why are flexible and timely tools needed for measuring NCDs. Roberta, over to you.
Thank you, Silvana. Thank you very much for this kind introduction. It's really a pleasure to be here today and help to set the scene of the importance of using telephone service to complement the work that we do on NCD surveillance. We do need tools that help us to produce data in a timely manner, but also guide us towards the implementation of policies. And when we talk about innovative tools, we are actually trying to present this as an approach, as a way of complement the tools that we already have it. We'll ask next slide, please. So I want to start by providing this overview that we've been developing the region as a conceptual framework since we kind of work responding to the demands. Health systems, when it's fragmented, it does reflect on the surveillance system as well. But this is an effort within the region from us to put in one place all the elements that are relevant for integrating NCDs into the public health surveillance. We are not talking about building from the scratch something new, but just to complement and fill in the gaps that we need a lot, and where are the biggest caveats, where are the important elements that we need to have if you really want to monitor the complexity of NCDs and the burden of NCDs. So this is just an overview. I don't want to go in depth. We have this being presented in Brazil and the meeting on March for some feedback from countries. But the idea is to emphasize that for NCDs, we really need data from all the levels of care, from health promotion to palliative care. We need the information not only for those separate the prevalence that we normally have been doing, and it's an effort that we need to keep doing in terms of knowing the prevalence of tobacco, alcohol, individually, but also understand better the distribution and the population that are living with one or more NCDs. So we have estimated during the COVID that 24% of the population in the Americas were living with at least one condition. We talk about chronic conditions, and this is our aspects that are differentiate from different, let's say, strategies that we have used for public health. So here we have the dimensions that you need to be aware. So we have social determinants of health, but we also have commercial determinants of health that impact with the unhealthy commodities that cause and expose people for getting sick and developing NCDs. We look into the burden of disease traditionally, but we, as I mentioned, need to look beyond that. And also to be clear that data for NCDs come from outside the health sectors as well. On the right side, we have highlighted some of the key data sources, and today when I talk about population-based survey, what are the strengths. We don't have one data source that responds to all of the needs that we have. Would be a paradise if we get there, but we need to understand where we can, what are the strengths and where are the challenges when we are using some data. And today we want to talk about telephone surveys as one strategy to fill some of the gaps in the data that we have. And finally, I just want to emphasize here on the left side on the needs of data, on why you produce surveillance, why we are implementing surveillance, as Dr. Jarbas Barbosa and Silvana Luciani mentioned as well, that surveillance is an essential public health function, and which means that we need to strengthen national institutional capacity to respond accordingly. And we need to take advantage of the movement of strengthening information system for health and digital transformation to really help us to be able to make surveillance for NCD stronger. But one of the aspects that we need to be aware when we are establishing our surveillance system for NCDs is related of these key elements. We have produced data for risk factors. We have produced data for the death and the burden as well, but we need to be more, we need to address some gaps that we have. So data on the implementation and evaluation of health policies, use it for prioritization exercise, have information on the unmet needs of this population. Household surveys, mobile phone surveys, school-based surveys are key when we gather, for us to gather data. Facility-based data is essential. It's one area that we need to improve in the region. We've in the past have faced lots of challenges. The change is coming. We are happy to see we are improving capacity in many countries to finally be able to report on hypertension control, or understanding where are the lacks of essential medicines and technologies exist. But the data from, as I was mentioned, we need to have clarity on what the data provides to us. Data from facility are essential, but provides estimates, provided the idea of those that have gone to this facility. For when we need to look into the access to care, barriers to access of care, then we need to use different other sources to gather this information. And it's where telephone surveys come handy to help us fulfill these gaps. Next, please. And just one overview of what I was saying. We do have many tools, and you might know the tools that we have, protocols that we have for collecting information at the population level. Household surveys are key for measuring overweight and obesity, diabetes, and hypertension, for instance. School-based surveys are key. It's GSHS and GITS has been the tool that have provided information throughout for more than 2 decades in terms of NCDs and risk factors, mostly risk factors in the youth population. But here we needed a tool that would help us to understand gaps in policies and intervention. So telephone surveys come handy in this point. Can you please next? And that's how we see valuable. But most of the time, when we look into telephone survey, the first questions we have is, what is the penetration? What is the distribution? How are the coverage of population using telephone survey? And specifically here, I want to show and talk about mobile phone surveys, which is the experience we have had at the region. We developed one tool and one approach during the COVID pandemic to produce data for NCDs and data related with COVID as well. But this is a report launched by ITU, the International Telephone Union, in 2024. And then you can see the distribution Dr. Jarbas Barbosa mentioned in the beginning of this webinar, that we have an environment that facilitate in the region the use of mobile phone survey. He mentioned 4G and 5G, but if you look at as well with 2G, which is an element that facilitates use of CATI mode, would be essential for us to do. We still have some gaps in the rural areas, but the coverage at urban areas is almost 100% when you look into all the technologies. Population in the region of the Americas, the majority of population live in urban areas as well. But again, we have challenges. We need to look into the places that we might not be capturing well, but this is a very important tool for us to use. Also, in the region of the Americas, we look into the distribution of ownership or ownership of mobile phone service. And if you look at the distribution between male and female, and the region is pretty much 1 by 1. So we have the possibility of reaching different groups when we look into the ownership of mobile phone service. Next, please. And this is the question that everybody makes, right? When you talk about mobile phone, what is the coverage? And this is, if you look in the bottom, the different types of technologies. So 2G, 3G, 4G, 5G, and how this is available in different countries in the region. As I think to help you, to guide you to understand this, the majority of the population, or more than 75% of the population, have at least one of this coverage. And we, for the one that we are promoting, the use of CAT requires at least 2G to be able to apply. So the region, we are pretty good in terms of mobile phone network. There are some countries that we need to be aware of the coverage, for instance, for 3G, if you want to use the technology farther, but which is Haiti, Guyana, and Cuba. But 2G is also much available in the region. Next, please. And now I want just to emphasize this approach of using mobile phone surveys and our experience in the region. What are the areas for NCDs that we should think better that we should take into consideration to gather information? So mobile phone surveys or phone surveys are useful for producing data in a timely, can be representative of the population, complements our routine surveillance and household surveys, our facility-based data that we need so much. It's very useful during public health crisis. We saw this during the emergencies, during the COVID-19. It helps us to look into our best buys. We know so far in the region which countries are really have passed laws or have policies to respond to the best buys. But here we can kind of go into the population, see what is their exposure to these policies as well, asking about knowledges, attitudes, and practices. We also can track the unhealthy commodities, and I want to give the example of the new emergent tobacco products, which is something very important to us to understand the dynamics within the populations and in the different countries as well. So, and finally, just to mention one of the area that we haven't explored much, but it's important, which is to know more, use this tool to know more about the barriers to access of care. Next, please. Brief overview, you see the methodology available at the PAHO website. We developed this during the COVID time in collaboration with CDC and RTI. So it aims to adult population. That's how we have tested so far. We recommend using short questionnaires to address specific needs. We have used, and we think, the best mode so far. There are so many exercises and there are people investigating better, but so far it seems for the region, the CATI mode is the best mode to be used, but you need to train interviews. The sampling, we are using probability sampling of mobile phone numbers. We stratified by mobile network operators. In a few countries, we were able to stratify by some geographic areas. I think it was the case of Bolivia, if my mind is not tricking me wrong. And then we allocate the sample based on the distribution of country population by sex and age. We select the numbers using random digit dialing. It's nothing new that or different that people that work in sampling and surveys does not know. In our experience, we are recommending mobile phone survey for the reason that the population is moving to this. Landline service has not been included in our experience. And this is one point that has been key. We had the opportunity to do this service in 4 to 5 weeks and get the information for different situations. And I think this is a valuable, let's say, feature in our surveillance toolbox to have. Next, please. And just one overview of what we have done so far. So we started this experience in using mobile phone survey in 5 countries as phase 1 during COVID. You all know the service interruption impact a lot on the life of those living with NCD. So we were asking about interruption of treatment because COVID. We were able to understand better this in countries. We later on tested using questions for policies and interventions related with best buys, which also adds more information for many strategies and policies that we are aiming to implement. And now in the 3rd phase, in collaboration with Bloomberg WHO, we are implementing a questionnaire in Ecuador where we are looking into the best buys, new emergent tobacco products. And we are very pleased to have Dr. Tom Frieden here because we have collaborating and he will speak a lot about on the use of questions to gather information for primary healthcare. So those are elements that we are seeing key for us to complement our surveillance toolbox to get data that is needed. Please, next. And just to illustrate now, so if we look into the best buys data from some of these countries, we have Suriname and St. Lucia that were interested in knowing more about the campaigns that they have developed for increasing physical activities to understand how these campaigns that they were doing were penetrating within the population. Next, please. We also had data, and I'm pleased to have colleagues from Uruguay here today, and to understand better one of the best buys, which is bans on or comprehensive restriction on exposure to alcohol advertising. So you can see in the population where people are seeing advertising for alcohol in different medias modes. Next, please. And also look into understanding what is the perception or awareness of the population that think that e-cigarettes or vaporizers with tobacco are less harmful than cigarettes. We clearly can see that among the young males, among this population, they see this, that it's less harmful. So it's important of us to know as surveillance to identify where are the areas, where are the population that has been more targeted by these advertising, promotion, sponsorships, and the population. I think next, and finally, to illustrate, this is what I was mentioned that we use during emergencies, during the COVID-19 pandemic. Within all these countries, we asked the population, those that were diagnosed with high blood pressure, those that were using medication for hypertension, but they had to stop because COVID. So this is a panorama that we using telephone surveys, we can quickly gather information. Next, please. And to finalize, just to mention that the value of these tools is to complement what we have and to use these two features that we can produce data in a rapidly and flexible way, adjusting to needs. Here, we can produce information specifically for a special initiative in a country. For instance, if there is a need to understand better in terms of ultra-processed food or in terms of nutrition, we can produce the information in a more quick way to support some policies, to support decision makers, to push for policies that will protect population from these unhealthy commodities. We can have it as a time series, as Brazil has done, and will share with us today how they have been using the information throughout the years to really guide them on the direction of NCDs and the risk factors as well. And we can explore it to initiative. We could use this tool to produce data for many countries and have comparison to understand better these dynamics in different health systems of the barriers to access. So we can have comparability as well and produce in a big number of countries this information. And finally, I mentioned before the use of this during public health crisis. I also want to say that there are a lot of potential for improvement on the sampling strategies, using household surveys to establish a panel to follow up, or even to follow up with those that are having access or not to healthcare facilities. So, and now we'll stop here, and thank you very much. And I'll look forward for the continuity of our session.
That's wonderful. Thank you very much, Roberta. That was Roberta Caixeta, the PAHO Regional Advisor for NCD Surveillance. Excellent summary of the RAMPS survey. RAMPS is the Rapid Mobile Phone Survey. And as she noted in her slide, we have the tool available on the PAHO website, and we encourage everybody to reach out to Roberta and visit the tool on the website to learn more about it. We also have a tremendous amount of data that's generated by the surveillance team on NCD mortality, morbidity, monitoring of trends and indicators available on the PAHO Enlace website. And we'll put the link in the website for those who want to access our data. So thank you again. And moving along in the program, we're really excited to have our next presenter, Dr. Tom Frieden, who's the president and CEO of Resolve to Save Lives, a true public health advocate known to many of you who are on this call. And he's sharing some of his time and expertise with us today to talk about monitoring access to NCD quality of care. Over to you, Tom.
Thank you very much, and felicitaciones, Roberta. It's very impressive work. I'd like to talk with you about monitoring access to NCDs and a really important approach that Brazil and Colombia and other countries in the region have started, as have other places around the world. So just I want to start with a story that earlier this year I was visiting India, where we have partnerships, and I met Jagannath. He's a 70-year-old man, perfectly healthy, except he was feeling that his back was hurting. So he came in for care, but because they screened with a validated blood pressure monitor, they found out that in fact he was not okay. His blood pressure was dangerously high, verified on multiple retakings. He had no idea that he had high blood pressure. But because the WHO Hearts protocol, which is being implemented in many countries of Latin America, was being implemented there on that very same day, as per policy, he was started on treatment. And so he was happy. I was happy. His risk of having a heart attack or stroke was drastically reduced. And he also got treatment for his bad back. The fact is, we've had 50 years of commitment to primary health care, but other than in Latin America and parts of Europe, not a lot of progress. Latin America and the Caribbean have achieved some important areas of progress, but still in the NCD care, there has been real gaps in quality. We don't have the kind of focus on control that we have in the communicable diseases, which has been so important in driving progress from the tip to the toe of the Americas with terrific projects and programs. Most NCDs could and should be treated in primary health care, as Jagannath's hypertension was. Quality of care begins with quality data. Each method has strengths and weaknesses. Each method has its place and has unique information and perspectives. Health information systems are very important, and I'll discuss that more in a bit, but they miss people who aren't coming in for care. Facility-based surveys have value. Examination surveys are very important because we'll never get valid community-wide control data without examination surveys. You can't find out through the phone yet what someone's blood pressure is, but phone surveys also have a very important role. I do want to mention something I encourage you to visit, www.hearts360.org. This is an example of the hypertension dashboard. What we've learned is that in clinical care, dashboards are powerful, but work lists are even more powerful. And the Hearts 360 dashboard, which is available, and we would love to have partners in promoting this, is a way of rapidly improving care in primary care, and it gives you really important data. If you are the healthcare system, you really need to know one thing: how many patients are on treatment adequately controlled? And for patients with diabetes, that's especially important. And you want to know how many people with diabetes are on statin. All of these things are basic. In the infectious diseases, we hold programs accountable. What's your tuberculosis success rate? We haven't done that in the NCDs, but we need to. And I know that the Latin American and Caribbean region can be an absolute pathfinder in this area. So I look forward to seeing further progress. Only Costa Rica reached the 50% mark from the region, not the US. Oh, sorry, and Canada, Costa Rica and Canada both. But other countries down in the 20% rate or 30% rate or 40% rate. But to get at least half of all of the people who have high blood pressure on treatment and controlled, if we did that globally, it would be 76 million lives saved. So it's very important. Now, moving on to the question of phone surveys, population surveys are an underutilized tool, and they've been called for by WHO, by PAHO. You heard the very strong message from Dr. Barbosa, who I've known for Jarbas Barbosa, who I've known for many, many years. And he's right. And so how can we do this? Population-based surveillance captures the missing voices. It documents financial and other barriers to care. It reveals the true disease burden because population services surveys consistently show higher NCD prevalence. It also identifies intervention priorities, what's working, and it addresses the lived experience of patients, and it can track differences among areas, over time, and among countries. New questions can be incorporated into ongoing surveys. So we began this project, almost 2 years ago. And really the model for it, and I was really glad, Roberta, to see you mention the global tobacco surveillance system. One part of that is what's called TQS, or Tobacco Questions for Surveys. These are the core of the core. It only takes two questions with very clear skip patterns to get standardized tobacco use, smoking prevalence that we can compare apples to apples, one country to another, one part of the country to another part of the country, one part of the country last year to next year to 5 or 10 years from now. That's a great surveillance system. PAHO has been in the lead in that. Many of your countries are implementing this. And you can see some of them here. This is actually a graphic from 10 years ago. So there are many more countries by now. But here's the striking thing. We don't do this for primary health care. And that's what led to the Primary Healthcare Questions for Surveys, or PHCQS project, to develop a globally standard model of population surveys, which can be phone or in person, some places prefer in person, to enable countries to assess, improve, and expand the availability of services, to inform evidence-based policies and assess whether our programs to implement those policies are working or not. What gets measured can get managed. What doesn't get measured is unlikely to get managed. And what we saw strikingly is that there has been a project through the United States-based Commonwealth Fund in OECD countries, including some in Latin America, to track primary health care. But except for one-time survey in the Caribbean, this had never been done in lower or middle income countries or elsewhere, though many countries have this, but it hasn't been standardized. So we began a collaborative process. We don't claim to be the experts. We do want to convene others. So we had 15 countries, many global organizations, and then we had 2 countries volunteer to pilot test this, Brazil and Bangladesh. And we identified specific domains: availability, accessibility, affordability, and acceptability. This was the consensus of the group, that we needed to have all of these 4 included to get to the basic question of how is primary healthcare for you? And there are specific questions for each of these. Availability. When you need routine health care, is there one person or place you usually go to? Accessibility. In the past 12 months, was there a time when you had a health problem and needed medical attention, but you did not get health care from a provider? Affordability. In the past 12 months, was there time you had to borrow money or sell valuables to get care? And I'll share with you some striking information about that from the PVS, the People's Voices Survey, which is a closely analogous project for a standalone survey. For this survey, we're really hoping that these core of core questions you can incorporate into various surveys. We're discussing with the STEPS group to include in those surveys. We were discussing with DHS to include in those surveys, but I don't know what's going to happen with DHS. Acceptability. Were you received well? Would you recommend this service to others? And I have to really give a shout out to Colombia, which had done this so well that they were able to tell us, well, these 2 different questions give you different answers, and they're useful for different things. So very important insights. The vision is to standardize this, to integrate it into different platforms, and then to have it. We've been talking about Alma Ata, 50 years, Almaty, primary care, but how will we know if we're there? How will we know if we're making progress? This is not the only way, but this is one way. What do people say? Because unless you do a population-wide survey, you may be fooling yourself. You may think people have care, but they may not be in care. there are other ways that are very important as well, like Hearts 360 within the healthcare system. Now, this is striking data from Nigeria, which implemented the People's Voice survey, and that has triggered more interest in providing medications with lower or no co-payments. But strikingly, a large proportion of people had to either borrow money or sell things to get routine or ongoing care. In Colombia, extensive experience, and it led to changes in which, as I understand it, which insurers were approved to continue. In Bangladesh, very interesting, although many challenges, very high level of satisfaction with care, very different from another country where the reported satisfaction of care was very low. Well, some countries have cultural differences in what expectations are, but still, you have some benchmark there. You can compare it male, female, young, old, urban, rural, different provinces of the country, different countries at the same time, the same country over time, as Colombia did, different insurers within the country. So this is a very powerful technology. And we just hope that more people will put this into your ongoing surveys. And with that, we'll have more valid, more important, and more reliable data to track where we are with primary health care and to steadily improve the quality of our implementation. Latin America, I will say, and PAHO have been absolute leaders in so many aspects of health and of primary care. And we look forward to seeing you achieve great things with improving care of people with high blood pressure, improving statin use for people with diabetes, and we know that you can make huge progress. So hats off to you. Thank you for the great work you do, and we look forward to continuing to collaborate with the PAHO office and with countries throughout the area.
Wonderful presentation. Thank you very much, Dr. Tom Frieden, President and CEO of Resolve to Save Lives, talking about the importance of integrating questions in your surveys that address primary healthcare services for NCDs. And we saw the value of having that data to really help influence changes in policy. We all know that in Latin America and the Caribbean, we have huge gaps in access to services. In fact, some surveys show that about a third of the population still doesn't have access to primary healthcare services. And in the NCD space, we know that there are large gaps in underdiagnosis, undertreatment, and in control. In fact, we know in hypertension that only about a third of the population with hypertension are actually achieving control. And Dr. Frieden reminded us today that we must take advantage of every opportunistic visit to a health clinic to measure people's blood pressure and diagnose hypertension and offer treatment, of course. So thank you again, Dr. Frieden, for your excellent presentation, for the wonderful partnership and collaboration with PAHO on the Hearts Initiative, on salt reduction, trans fat elimination, and public health overall in general. So thank you again very much.
Thank you.
Okay, great. So we're going to continue in the program. Vamos a seguir en el programa y solo para recordarles que tenemos
Just as a
traducción
reminder, we have
simultánea
simultaneous
en el
interpretation
botón que
available.
dice interpretación
All you need to
porque la
do is
siguiente
click
presentación
on
será
the
en
translation
portugués.
icon at
The
the
next
bottom of
presentation
your
is going to be
screen.
in Portuguese. So I'd like to remind everybody we have simultaneous translation. It's in the bottom button titled Interpretation. And in this session, we will hear about the experience of Brazil with Vigitel and using telephone surveys for NCD surveillance. And I'd like to welcome Dr. Luis Antonio Menezes Jr., who is the General Coordinator of NCD Surveillance in the Ministry of Health in Brazil. Thank you for joining us, Luis. Over to you.
Olá a todos, boa tarde.
Hello, everybody. Good afternoon. As you heard before, I'm going to talk in my native tongue, Portuguese. So I'll be using the translation. Please go to English. So once again, on behalf of our coordinators, Georgia, and I would like to greet all the colleagues here, and I'd like to greet my previous speakers also on their excellent talks. Also, I want to thank thank you for allowing me to participate here. It's an honor to be here and participate at the general NCD coordination of the Brazilian Ministry of Health in this important cooperation and dialogue space. Also, I'd like to thank PAHO for inviting us. In this talk, I will give you an overview of Vigitel, which is our phone survey system. For almost 20 years, it has monitored risk factors in protection against NCDs in Brazil, emphasizing some of the recent innovations we have implemented. To give you a context, the Vigitel is in the scope of the epidemiological service of the NCDs with the Ministry of Health, coordinated by the SGMT, CGDNT, and we formulate, implement, and evaluate public policies. These actions are planned to approach health conditioning factors. So after the systematic sampling and analysis of this data, as well as dissemination of the information that's generated, we are able to make advances. Vigitel is one of the three main surveys coordinated by our service. We also have PENSE, which is the school survey system. The most recent one was finalized in 2024. Also, the home-based survey system going from 13 to 19. The third edition has been implemented right now. And finally, the service that I will present to you, which is the Vigitel, which takes place annually since 2006. We have the 24 reports being elaborated right now, and Vigitel 25 reports has been done right now. With these three sampling systems, they create a robust system for monitoring chronic diseases in Brazil. They also allow us to monitor progress towards sustainable development goals and also the strategic plan for NCD control in Brazil. Vigitel was built on two strategic documents by WHO, the World Health Report 2000, which emphasized the need to improve health systems, including monitoring as an essential service, and the STEPS, which presents a framework for standardized surveillance of risk factors, obviously focusing on simplicity, international comparability, and the feasibility for low and middle-income countries. These were the basis for the Vigitel using methodological robustness, but adapting it to Brazil. A little bit of the Vigitel's history. It has a history marked by continuous innovation. It started in 23 to 2005 when they carried out the first pilot phases in the city of São Paulo with approximately 2,000 interviews, and then expanded to 5 other capital cities. This stage was crucial to validate the methodology developed in partnership with the University of São Paulo, USP, and in 2006 we officially implemented the system in all capital cities of the country and Brasilia. One of the differences we still maintain is agility, which is important for this monitoring system to take place. And as it advanced until 2020 with the pandemic, we have faced many challenges and opportunities. So we had to operate with reduced sampling, but we were able to guarantee continuity in the system. 3 years later, in 2023, we took an important step, as you heard, which was incorporating mobile phones, significantly increasing populational coverage. 2025, a new milestone with the Vigitel being expanded into countryside municipalities, and this increased its the representation of the data. In parallel, we implemented the structure we call core and rotating, which allows us to have more agility in investigating emerging topics in health. In the first edition of Vigitel in 2006, as I said, agility is a key factor. In 2006, we were able to publish results in less than 70 days after we finished sampling. This was a milestone for monitoring. Vigitel indicators are based on consolidated, international consolidated methodologies, guaranteeing comparability and relevance. We have many different sources, including via RFSS, STEPS, the WHO's Global Health Survey, also OPAS, and also using the school-based health survey, the Carmen network, also with some guidelines for the Americas, and also an important step with the organization of workshops, which many PAHO colleagues have participated in, offering us field update with participants from the university, health services, to include emerging demands, to improve questions. And this plurality of sources allows Vigitel to include global standards with Brazilian and American and Latin American health priorities. About the indicators, Vigitel accrued a robust portfolio of indicators, including nutritional conditions, morbidities, sleeping behaviors. So it was a very recent inclusion, which is very important, especially for NCDs. Also, other indicators such as breast cancer, alcohol use, tobacco use, and driving behavior or traffic behavior. Apart from the main topics which we have followed since the very beginnings, we also have isolated sessions on emerging topics such as oral health, dengue actions in 2012, COVID in 2021, UV protection means from 2007 to 2010, and more recently matters relating to online betting. About Vigitel's methodology, it originally was designed in 2006, considering, as the colleague said, that landline coverage in the capital cities of the country would give us a representative sample of the adult population. So, but landlines were replaced by mobile lines, so the process needed to be changed, and we added mobile telephony in 2023 to maintain its representativity. So this methodology enables us to randomly select numbers, and also these number sources evolved along the years. Initially, the numbers were gotten directly from the operating companies, by the companies, and we also had information on the zip codes involved until 2013. But after that, we no longer include those landlines. And after 2021, we use the records shared by Anatel, which is the Brazilian telephone controlling agency, and they are organized by municipal sets, and these are randomized to ensure proportional coverage for each capital city. Now, during the interview, mobile lines allow us to interview the person directly. Now for the landlines, we need to implement a second random selection to select to select an adult in the house where the landline is installed. In this process, to possibly correct sampling problems, we apply weighting actually, which is then classified and categorized by the rake method. And based on the populational census, we adjust these numbers by gender, age, and race, making sure that the demographic distribution of the sample is the same as the distribution in the population being studied. Now, since its implementation in 2006, Vigitel has maintained stable operational results, even after changes in communication technologies and also usage patterns by the population. This stability is very important because it ensures comparability of the data we collect, also time comparison, but it indicates a slight drop in eligibility for landlines in different editions, which reflects, which would give us information on where these landlines are. So especially in 2023, where, for landlines specifically, which this can be a reflection on corporate lines or landlines out of service, and also the inclusion of mobile lines, which sort of compensated for this loss. So we have eligibility of these lines, which was about 5%. Now with the the mobile lines reached 21%. So we do see an average variation of 3% since 2006. More recently, from 2018 to 2023, we saw a drop of approximately 10% every year. Another important indicator is the response rate, which also went down over time, going from 71% in 2006 to 34% in 2023. And also this requires attention and maintenance of the records we use for these interviews. In spite of all these challenges, we see that the refusal percentage is still favorable in 2006. So in 2023, we had 4% for mobile lines and 4.5% for landlines, which emphasizes the quality of these interviews and also how well the interviewers have worked. An important aspect is interview duration, which we also have monitored over time, reflecting the incorporation of new topics. And this is sort of a dilemma because we need to maintain traditional indicators, but we also need to monitor long-term trends without compromising quality of the interview. And that is why we have thought about the possibility of rotating systems, which are topics used alternatively, which gives us some flexibility in the interview without extending the questionnaire too much. In 2025, as I mentioned, we had an important milestone or landmark for Vigitel. The tender process was very successful, and we are extending it to the municipalities and countrysides, improving the representation. And we also include new indicators, especially on alcohol, tobacco, and sugar-containing beverages, which are becoming more important in the current tax reform discussion. Also, very importantly, we strengthen the dissemination channels of these interviews with our partners. So Vigitel not only offers these main communication strategy, Vigitel also counts on new sampling and intervention and dissemination strategies such as SMS, WhatsApp, and digital assistants improving social participation. What are the perspectives? Vigitel is still a robust strategic system for monitoring of NCDs and protection against chronic disease in Brazil. Still, we understand that the model needs to be monitored and improved, and one of the main challenges is to improve multimodal sampling and interviewing practices. Some pilot studies are being created, such as online panels with promising results. They are cheaper with shortest average response time, but they still require care because they need to be quantified for certain indicators. They may present some differences in the socio-demographic profile of the respondents. And the use of online panels for usability is increasing and it's well received by the population. So that is an important aspect. And finally, as I mentioned before, weighting the estimates by race or skin color also gives us an important advance, ensuring better accuracy in representing health inequalities, allowing for control and monitoring of NCDs, and the creation of more equitable public policies.
Em painéis interativos, como o painel de obesidade, que está aqui apresentado, que está hospedado no Centro Nacional de Inteligência Epidemiológica aqui da Secretaria de Vigilância em Saúde e Ambiente. E também outros painéis, como o Indicadante, que está em desenvolvimento, que irá incluir informações sobre danos,
also developed to include risk factors and protection with data and research about other elements, providing broad information, public access, and also interactivity to the data. Now, these are some institutional websites with further information for those who want to access the data of Vigitel. Once again, I would like to thank you all for the invitation and the opportunity for sharing our experience in Brazil. And of course, I would be more than thrilled during the debate.
Brasil con Vigitel, con las encuestas con teléfonos móviles. Y es un buen signo, ¿no? Que
so this is a great sign to hear about what's happening in Brazil, to see how much has been achieved and how many surveys have been conducted. It's a very sustainable tool, right? So thank you so much for sharing your experience with us. And it's been very motivating for those of us who have been listening to this and learning all about surveillance. So thank you for telling us about these mobile phone surveys. Thank you, Luis. So we're now going to hear from Uruguay. We would love our Uruguayan colleagues to share their experience with us. We have Jimena Moratorio, who's the coordinator of the National Nutritional Program from the Ministry of Public Health, and Jimena Heinzen, who's the coordinator of the National Program for NCDs in the Ministry of Public Health. And so they're going to talk to us about the RAMP survey and how they have managed to measure the implementation of front-of-pack nutritional labeling. Hi, everyone. I'm just trying to share my presentation here. Can you see it okay? Great. First of all, thank you so much for the invitation. Jimena Heinzen was invited to join, and she invited me. So we don't have as much experience, but we're going to be telling you a little bit about how we have been tackling the issue of overweight and obesity in this area of NCDs. So we're going to tell you about our front-of-pack nutritional labeling, which began in the year 2017. And there was a regulatory process that was carried out in Uruguay in order to be able to implement a FOP, front-of-pack labeling policy. So first of all, we set up an interinstitutional working group, and we compiled international experience, we analyzed evidence, and then we selected the critical nutrients, and we established thresholds to define what was meant by excess. And all of this was based on international recommendations. Specifically, initially, Uruguay opted for adopting a model used by PAHO. And we've had some changes since then, but that's not what we're going to go into today. So we also generated local evidence in this working group with the academic sector, and this was used in some countries to develop their own policies, and each of the decisions that was taken was based on evidence. Every single feature of the graphical system was backed up by research studies. And in this case, we also included a survey on consumer perception about the adoption of this policy. This was not carried out via mobile phone surveys, but rather through digital means. So this was another way of being able to be relevant to our modern world. So this is what helped us to take decisions, because this type of policies are very questioned, especially by the industrial sector. So to be able to have a favorable perception from the population in terms of this tool was very important for decision making. So we then submitted the draft decree to public consultation at national and international level. And for the international level, that was through the technical barriers to trade of the WTO. And we received some of their inputs, we incorporated them, we made the threshold limits more flexible, and we extended the implementation deadlines. And finally, the decree was signed on the 29th of August of 2018. And we have an implementation deadline, which was March of 2020. So a few changes were made after that date, as you all know. That was largely due to the audit. And then there was a change in the government. We had the pandemic, and regulations were also changed during that time. And there was also an extension for the deadlines, which was extended to the 1st of February 2021. Here we see some of the characteristics of our FOP labels. We have a visual graphical system of nutritional warnings, which is in line with the best practices of PAHO.
Como una de las que había sido validado por los estudios.
And this was verified by the research studies that were carried out at a national population level. And so these are other characteristics of these labels, and the algorithm for implementation is directed at processed and ultra-processed products, because these are the ones that include these addition of critical nutrients. So I'm going to give the floor to Jimena. So what we wanted to share was this process in terms of front of packet labeling and the surveys that were carried out in our country, which allowed us to evaluate over the period of about a year and a half, the implementation of the regulation and how the population perceived it, and what attitudes we saw in regard to this subject. So Roberto told us about this earlier, but specifically in Uruguay, we carried this out through mobile phones, and we divided it by 6. We carried out 2005 interviews, and we're going to tell you more about this. So in Uruguay, there were various modules, and what we want to highlight today was the impact and the possibility of being able to assess certain public policies through this. So, for example, issues on purchasing decisions or foods that were selected, and whether or not they were influenced by these front of pack labels, whether it influenced people's decisions to buy, for example, and what people thought, for example, about applying a tax to sugary drinks or to alcoholic beverages. So we also asked questions about eating habits, alcohol consumption, and smoking. So this data was collected in October of 2022. So I'd just like to share with you some of the results that we found. This isn't broken down by sex, but we see the percentage of people. So we had 76.7% of people said that they did notice the front of pack labeling. And an interesting thing to highlight has to do with purchasing decisions. So it has to do with the influence of the front of pack label on people's decisions to buy certain products or not.
Escuchamos bien, pero un poco lejos.
We hear you okay, but for very far away. The sound isn't great. So about 21.5% said that they didn't buy certain products given the front of pack label. So that's 21.5% of the people that responded to the survey. So we see that the front of pack labels influenced people's purchasing decisions. One of the things that was mentioned today by my colleague is that in Uruguay, there was a new regulation that was applied, very new. And we carried out a survey about it, not via telephone, but via internet. So we carried out this survey with internet users who were older than 18. And through certain social networks, there were people that chose to participate. And then we did a weighting by sex and age group. So Facebook was one of the platforms used. But one of the things we were interested in highlighting is that 10 days after this regulation was implemented, 87% said that they knew about this regulation, and 58% said that they had changed a purchasing decision after having seen the warning label. Finally, if we understand this tool as something that can have different roles, different functions, we wanted to share its use as a way of evaluating public opinion or its influence on certain public policies or people's perceptions and how that affects policies. We thought it would be interesting to point out that 30% of people thinks that an increase in the price of sugary beverages would influence their purchasing decision. And along the same lines, a slightly lower percentage, 25.5% of people interviewed, said that an increase in the price of alcoholic beverages would influence their purchasing decision. And so you might think this is something that's very difficult to change, right? Because these are the consumption of alcohol and sugar is very ingrained into culture. But we see that 67.5% would support a tax on alcoholic beverages. And so we're also working on an issue of these products being available for children. And so we're evaluating a project that has to do with that. We see that along these lines, 76.6% of people interviewed said they would support a ban on the sale of products with a front of pack nutritional label in educational centers. Jimena, back to you. Okay, so to tell you a little bit about this last point, since 2013, Uruguay has a law enforced which has to do with promoting healthy food in educational centers. And this ley provides certain requirements to certain institutions, and the Ministry of Health has established a list of recommended foods that can be sold and advertised in educational centers. So initially, this law banned the advertising and promotion of these products in educational centers, but they were still allowed to be sold. In the year 2022, after the front of pack labeling was implemented, a new ordinance was issued in 2022, which approved a new list of approved food groups. And we introduced the front of pack labeling by classification. So we have these three groups. You have natural food and drinks that have been minimally processed. You have the foods that have been made at points of sale that include recommended ingredients and adequate proportions. And then finally, you have packaged products that don't have FOPLs. So those are the three groups. After this ordinance was signed, a modification was made in the law, modifying the article that established the provisions that would also allow it to be sold. So that's to say that from the year 2024, this policy was measured in terms of the population's perception of it through phone surveys. And it has led to this now being a ban has been put on products with the food warning labels being sold in educational centers. And so we also want to integrate this national roadmap to accelerate action to fight obesity.
Because of the penetration of mobile phone surveys, of mobile phones, as Roberta showed in her presentation, with a lot of network coverage and high use. So as countries invest in building the NCD surveillance systems, and as many of you who are probably working in NCD surveillance are investing in strengthening the surveillance system, we encourage you to consider using telephone surveys and using the PAHO ramps survey, or using those core primary healthcare questions that Tom Frieden presented in your surveys to be able to complement the household or population-based surveys that are already ongoing. So let's continue to work together to help improve the capacity of NCD surveillance in our region, and to leverage all the digital tools that we have available to help improve NCD programs. PAHO, of course, remains committed to work with all of you to support member states in improving NCD surveillance and NCD programs overall. So thanks again. And I look forward to having you in our next webinar that we will be presenting, in fact, next week on July the 25th, where we're going to talk about NCD best practices, and we're going to focus on NCD primary prevention and risk factor reduction policies that countries in the Americas are implementing. So please join us next Friday at 11 o'clock for a continuation of our PAHO NCD series. Thank you, everybody. Have a great day. Muchas gracias a todos y a todas. Que tengan un buen día.
Thank you, everyone. Have a great day.